Live now.
Hi, good morning, everyone. Welcome to another edition of Live Talk of Journal of Cardiac Surgery. My name is Urbaz Hamid. I'm an integrated CT surgery resident at Yale, also associate editor of the journal. We're joined by several esteemed cardiac surgeons again today for this live talk. I will introduce everyone. We have with us Dr. Arman Kilic. He is joining us from Medical University of South Carolina. We have Dr. Kaki Balsara, who is joining us from Vanderbilt. And we also have Dr. Ashish Shah, who is also joining us from Vanderbilt. And we have finally Dr. Gianluca Torregrossa, who is from Lacanau Hospital, but currently at ICC conference in New York. He has also joined us for this live talk. Thank you everyone again for joining us. We're going to be talking about two recent publications on the journal related to heart transplantation. One of them, led by Dr. Keki Balsara and Dr. Ashish Shah, is about heart transplantation during COVID-19 pandemic. And we have another one which talks about predicting survival using machine learning, and that has been led by Dr. Arman Kilic. Gianluca.
Thank you. Excellent presentation, Irbats. And I'll give the floor. We start with Dr. Balsara just to tell us a little bit the findings of this paper that was published in Journal of Cardiac Surgery. We are here for Journal of Cardiac Surgery, and we like to take one or two papers, put them together with the authors, and have a 45, 50 minutes chit chat, try to learn something new. So, Dr. Balsara, Keki, please. Take the floor. Tell us a little bit about the paper, your findings, and what made you write the paper. Thank you.
Brilliant. Well, thank you very much for the opportunity to chat with you all today. Our paper, the title of it is Prioritizing Heart Transplantation in the Era of COVID-19. And in many respects, the genesis of why we chose to write this paper stemmed from the fact that particularly in the early days of COVID, it was quite unclear to us how it was going to impact the health system at large, but in particular, how it was going to impact heart transplantation. Certainly as an institution, we've been quite aggressive in expanding our both donor and recipient pool. We've used a variety of additional platforms, ex vivo platforms, as well as extended donor criteria to really expand the number of people who have access to transplantation. And the natural question that we had was that in the face of a global pandemic, which clearly put significant constraints on resources, how would we be able to provide this life-saving therapy to patients who perhaps otherwise would not have an opportunity to have a long and productive life? So this paper is a single institution study, and it comes from the early days of the pandemic. So it's actually, it began in March of 2020, where we began to look at these patients and continued through June of 2020. And quite simply, what we ended up doing was looking at our demographics for both donor and recipients for heart transplant and compared it to the year prior, before COVID-19 was an issue. And what we really found was that during that period of time, we were able to do a couple of things. Perhaps most notably, as opposed to a number of centers that either had to scale back their transplant volumes or even their elective volume, we as an institution really made a commitment to prioritize heart transplantation. And that is to say, we really focused our resources in making sure that we continued to transplant patients. We actually were able to grow our volume quite significantly over that period of time to the tune of about 30 to 40% over the prior year. There were really no differences as it pertained to donor or recipient demographics. And ultimately, outcomes were similar, which is to say, there was no change in primary graft dysfunction, there was no difference in survival. And I think what this ultimately demonstrates is that in spite of various constraints on the healthcare system, in this case from COVID-19, but perhaps in the future even from other issues that might arise, if a program is methodical and thoughtful about prioritizing certain life-saving procedures, they can be done safely and appropriately without having any untoward consequences.
Fantastic. Thank you so much for this sum up and summary of this paper that was selected. So I just started with a very quick question. How many transplants in your institution you have done during COVID, and how many respect of the average number of transplants that you guys do in the same in a regular year before COVID?
So certainly before COVID, our transplant numbers as a program were well over 100, about 120 transplants per year. Since the advent of COVID, those numbers have only grown, actually. And I think last year, and Ash, correct me if I'm wrong, I think the total number was about 140 for the program as a whole. This year, we are on track for similar, if not slightly elevated numbers. And so we really have not, thankfully, had any untoward effect from COVID, at least as it pertains to transplant volume, and perhaps more importantly, to outcomes. We have not had to compromise outcomes because of this.
Arman, I ask you your opinion about this paper. I'm sure you have read it. What is your taking home message? You are a heart failure surgeon as well. What is your experience in your own institution? Do you have a similar experience? Did you see overall a trending steady number of transplant performed? And particularly in a moment in which there is a huge shortage of resources that COVID pushed, for any healthcare system.
Well, I would congratulate and thank, Dr. Sean Balsara, because, with their large single center experience, some of these single center studies, I think, are very important in heart transplantation. I mean, the vast majority of literature utilizes things like the UNOS database, which is a rich multi-center, national experience. But what's lacking, I think, in a heart transplant are some of these large single center experiences, which can shed, unique insights. And so, we similarly had found a very large increase in our transplant volume. There were some confounders, including, new staff, new programmatic vision, new resources, et cetera, that were happening at the same time. But I do think that we were similar to Vanderbilt, probably, advantaged in a sense, because we actually got donor offers and pools of donors that we traditionally didn't have access to, at least in a prioritized manner. And that was probably because early on, probably in March 2020, there were probably programs that were slowing down or shutting down just from the density of COVID and the toll that it was taking on their respective health systems. So we went similarly, our program actually doubled in volume for heart transplant. We're less than Vanderbilt, but we're in the 50s for heart transplants. And prior to that, we were in the 20s. I don't think that's all from COVID. Again, I think it was multifactorial. But I absolutely appreciate and think that certain centers absolutely were advantaged in a way that they had access to, donors that they may not have had access to otherwise.
How was the coordination? And then I will ask Earbuds to have some question about how was the coordination during COVID for transplant in terms of logistic, flying? Did you guys have to be tested when you were going into a new hospital to do an organ retrieval? How was during the hot month? How was the status? What was the regulation that UNOS was applying for all of the cardiac centers?
Keki and Arman, if you don't mind, I'm just going to add a little bit to this because I think that's really the next part to flesh out the details of this study. I think that this document that Keki put together really doesn't completely tell the full story of what we had to do behind the scenes to make this possible. I think one of the so obviously the important takeaway is that despite the pressures of a pandemic and its unknowables, an institution really is able to prioritize heart transplantation because, really there were sort of impossible choices to make if you're going to do any heart transplants. In other words, who is sick enough? Do you prioritize only your status ones? Do you only if someone's stable with an LVAD? And I think, our institutional philosophy, it wound up being, look, this is a crazy, choice to try to make. So rather than say, well, we're only going to transplant people who are status one or who happen to be in the hospital, we're going to create a framework to allow transplantation to occur. And so there were a couple things that had to happen. Number one, we had to make sure it was safe for the donor surgeons to actually travel. So believe it or not, the airplanes had to be refitted with better air handling in order to protect the surgeons when they travel. Number two, we really wanted to rely on local recovery. And so, in other words, decrease the amount of traveling that we were doing and say, look, Armand, we trust you. Can you get this heart for us? And number three, even on our end, saying, look, we, in exchange, we will recover hearts for you in Vanderbilt, and almost closing the hospital to transplantation recovery from other surgeons. And interestingly, and that's probably a subject of another paper, is that, allowing other people to recover organs and we recovering organs for other teams in turn was also very safe and a very good practice that prevented potentially a lot of transmission problems with, as you're alluding to, having to test everybody going in and going out. I think, what we really worked on was ensuring that we had enough protective devices and that all the surgeons involved had N95 masks. Again, institutional commitments to surgeon safety and recovery team safety was really prioritized. And so as a result, I think we showed that you could do this. You could do it safely, and you would not really have to make what I think, again, is an impossible choice to say, well, everybody needs a heart transplant, but some need it more than others. I think doesn't make any sense to me. And institutionally, I think we really showed that when you think this through and have senior leadership commitment to help you, that means that our leadership, Seth Karp, Jeff Balzer, Wright Pinson, these are all people who lead our health systems. They actually supported us and allowed us to make some of these choices to be successful.
Thank you very much, Dr. Shah, Dr. Balsara, Dr. Kilic. So the question I was going to ask, I think, Dr. Shah, you kind of answered some parts of it. What I was going to say is, what is a blueprint that other programs can follow or can learn from the Vanderbilt experience? You were describing how you instituted some policies and made some changes in relation to COVID that helped you actually boost your volume. Some of them being changes to the aircraft, others being institutional policies. If there is an institution out there that is struggling with transplant volume due to COVID, what recommendations do you have for them? Where can they start from? That is my first question. And the other one is also tied into this one. In your paper, you described how people of color were able, you had more donation, they increased in terms of organ recipients. How did that happen? What was changed there?
Well, I'll just start, man. Keki can finish up and flesh out some more details. As I think I outlined a little bit, the number of programmatic things that we addressed. Maybe taking even a further step back, each program needs to decide, either you're going to do this or don't do this. You may have constraints by other forces, and whether it's the pandemic is affecting your workforce, is the pandemic, or some pressure on your health system is affecting your ability to do surgery, whatever the stressor is. First question is, are you actually going to do heart transplants? Is it a priority for your institution? And, maybe I would submit that, and it may be a little unpopular to say this, that if you are doing 10 heart transplants a year, in the face of all the other things that are going on, maybe it makes no sense for you to perform heart transplantation at your institution. That the struggle is not because you're doing something wrong. The struggle is that it's a real choice, that if you have other patients to take care of and to manage, that your resources are better served in focusing there. That's the first question for the health system to ask. And then the second, pieces are, when you decide that you still think it's important, you have to look at all of the features of that program and where it exposes risk to patients, to providers. Maybe that's the other take home for us, is that we actually focus on protecting the providers first. And then for the patients, we would think about cohorting them, having an ICU that's, quote unquote, COVID free. I mean, I think we now look at COVID as approaching almost endemic status. So that's really the next phase of this, is how do you prioritize heart transplantation when you've got endemic infectious stressors, and time will tell, what that looks like. And we had patients, and I'll let Keki finish up on this point, but we had patients that we protected them as best we could. They went home and got COVID, came back and either went on ECMO or died. I mean, how do you protect people from that? Obviously, vaccination is important for them, but it's a little less effective for the patient. Now, do you mandate that their caregivers are vaccinated? Do you tell that patient, look, we now have this horrible virus that's endemic. If you get transplanted, you don't leave your house. Those are those things that we have to start thinking about. It's sort of not what a patient would want to hear. Hopefully all these problems become less and less issue as this virus changes, and hopefully for the less awful. But those are sort of my thoughts about structural things. Keki, you want to?
I would echo much of what you said, Ash. I think in many respects, this paper, and early on, it was really looking at an individual institution, trying to figure out how do you do the practical day-to-day work of getting somebody transplanted. As we have entered, these newer phases of COVID, and as we look to see what the future holds, I really do think it's a matter of trying to understand, what does the healthcare ecosystem allow? How is it that you're able to provide care for individuals once they leave the hospital environment? I think Ash's point is quite a good one, which is to say you can have the best of intentions while they are in the hospital and while you have control over that environment. But once they leave the hospital, that becomes a much more challenging situation in which to protect these individuals. To pivot to your next question, Irbaz, about I guess racial disparity in transplantation, certainly I think it is well known that has existed across all solid organ transplantation, and that it pertains not only to access to transplant, but it even does impact what outcomes occur for individuals of color. I think in this small group, and what we've actually seen as we have looked at patients going forward since the time of this publication, is that we have been able to transplant individuals of color more so than in the past. Why that specifically occurred during COVID, I suspect, has less to do with COVID and more to do with programmatic changes that we have been doing. And I think a recognition on our part that there are barriers that exist to transplant that go well beyond the physiology. Recognizing things that, access to, whether it's insurance, caregivers, in Middle Tennessee, where Vanderbilt is located, we have an exceptionally large catchment area where individuals come from hundreds and hundreds of miles away from other states. And how do you help facilitate transportation to our institution? How do you have follow-up? And so I think this is more a reflection of us as a program beginning to recognize that the barriers that exist to transplant go well beyond the physiologic makeup of the patients, and that oftentimes are really driven by a lot of these social determinants that, while we don't have complete control over, there are things that as we begin to identify and recognize, we can set plans in place that address many of these things and can be an alternative way to expand the number of people who are eligible for transplant.
Thank you so much. I completely agree with you. I think that the racial disparity gap is trying to be filled up or reduced by a real new culture in medicine that is true for heart transplant as well for a lot of other single individual procedures. Arman, I ask you to give us a little bit of your personal insight. What do you think, as a heart failure surgeons, what you are going to bring out of this experience of COVID into the new profession? How does the life and the future of heart transplant will look like after COVID? What we can bring in our 2.0 life, or in this new life, as Professor Shah was saying, with this new endemic?
Yeah, well, I mean, I think that, much like everything we do in cardiac surgery, it's driven by, patient care and what's best for the patient, but also programmatically, because we want to make sure our programs are viable and they don't get shut down because of poor outcomes. So on the patient perspective, I think this experience and our discussion about heart transplant is sort of reflective of the bigger experience of what do you do with cardiac surgery in the area of the COVID pandemic. And I would argue that many institutions, I think, have developed sort of prioritized systems of how they want to handle their operations on a cardiac surgical standpoint. And, the discussion always comes, well, what's truly elective? Is there anything elective in cardiac surgery? You have a patient who needs bypass and they're having angina on and off. Is that really elective? Do they need to be done in a month? Do they need to be done in 3 months? That whole timing thing, I think, has been very institution specific. But as that relates to heart transplantation, to me, it's a no-brainer for the patients that are in the ICU. They're going to die. They have a few days, they have a few weeks. They're not going to make it out alive without a shot at transplantation, whether we're in the COVID pandemic or not. I think that the other more relevant one is what to do with stable patients who are at home, at least initially in the pandemic, to expose them to risk of having to come in, not just for their transplantation and for their surgery, but they're going to need frequent testing and frequent trips to the hospital. There's obviously the discussion of telemedicine and what can you do remotely to help manage those patients after transplant. So I think those were some of the relevant discussions on the patient side. I mean, we just sort of went full throttle forward. You never know when these patients, even if they're stable at home, we know that the trajectory is often not great. We obviously don't have a crystal ball to know how they'll do and what the natural history will be without a transplant. But certainly you can make the argument that it's poor enough that it's worth the risks of putting them through a transplant and getting them through. There are some studies that have come out, multi-center, looking at what is the impact of COVID on heart transplant recipients. So we had put one together on about 100 patients that found 24% mortality in patients who are hospitalized for COVID. These are heart transplant recipients, and 16% mortality for those that were symptomatic. And the average time from transplant to getting a COVID infection was about 5.5 years. So this included patients that were relatively remotely transplanted. Now, how does that compare to overall numbers and what their trajectory would have been, again, if they didn't get transplanted? I think we have to always think about the alternative if they don't get transplanted. So I think this experience, in my mind, just reiterates that we have to keep doing what we're doing, but try to do it in a safe way and develop systems-based processes and patient care to help move that forward. I think the other conversation piece, and there's a nice document from the ISHLT that provides guidelines on this. I think we've gotten better at the COVID recipient side of things. Patients who've had prior history of COVID and are now being considered for heart transplant. The question is how to manage donors who have a history of COVID. So there's been a lot of discussion about that, symptomatic, non-symptomatic, PCR positive, and so forth. And there's some nice guidance from ISHLT, but I think that's another opportunity to put data together and better understand that process as well, because whether we like it or not, COVID's good and part of our everyday life, and we just have to keep pushing, medical care forward and just figure out how to do it safely.
Fantastic. Before asking you again, Arman, to talk about your paper, I just would like to have from Dr. Shah a brief overview of the volume at Vanderbilt during the same times in terms of LVAD. Did you guys notice an increase or in the current moment? Are you sending more patients for LVAD or patients that are on the borderline with those concerns about COVID in fresh transplant? Has changed the way in which you see LVAD in the current era of COVID, or potentially even total artificial heart in the current era of COVID? What's your sense of mechanical circulatory support?
Well, I don't think it's no secret that my enthusiasm for mechanical support currently is not enormous. we had prior to all this had really pivoted away from mechanical support for a lot of heart failure, moved to an aggressive posture for heart transplantation. And then in parallel, the organ allocation scheme really changed in, just prior to all this. So, the reality in the United States, bridge to transplant left ventricular assist devices really has declined dramatically, and not driven by COVID. It was driven by the allocation scheme. So it really disadvantages patients, I think. And Armand and Keki may have other feelings about this, but I think it really disadvantages you to get an LVAD in America right now. And if your goal is transplantation. And so I think that so our volume of LVAD patients, both before, during, and after, haven't really changed, frankly. And whether we're talking about total artificial heart or talking about univentricular support, I think that state of states will remain the same, and it's going to remain the same because we really haven't, frankly, innovated on the LVAD side in a way to outcompete what the patients want. They don't want a drive line. They don't want batteries. They want to be able to travel and take a shower. And I think it'll be incumbent upon really the company at this point to really kind of think about that if you want to get back into this group of patients. Now, we're not talking about an enormous group of patients. The folks who are transplant candidates and transplant eligible, are probably, going to remain about the same. And despite efforts by all of the programs around the country to utilize donors that we didn't before, are we really making a huge dent in the total number of transplants? It's plus or minus 5-10%, here. Maybe DCD, that is donation after cardiac death, will move the needle a little bit more. But my feeling is that the overall use of MCS for heart failure really has to sit in the world of the destination therapy patients. And the last thing, just to bring back about this paper, I think one of the things that I think is very interesting is that by prioritizing COVID, I think what we're really saying is that your health system can adapt to almost any almost unimaginable stressor to allow you to take care of patients the way you want. And I think that after the pandemic, our real problem is staff, right? It's nurses and getting people to take care of patients. How does that alter your priorities for these programs? And so maybe the real story behind this is that, health systems that are adaptable, that have really thoughtful leadership, and that have a little bit of a drive to take care of their patients can really overcome almost unimaginable problems. And that, to me, is one of the other takeaways from Keki's paper.
Thank you so much.
Thank you very much, Dr. Shah. We'll now request Dr. Kilic if you can present your paper, and we'll go ahead from there with questions on that.
Sure. Well, our paper was on using machine learning to improve survival prediction after heart transplantation. So if you'll notice on the author list, and I think this is an important point, this was a collaborative effort by surgeons, but also by experts in AI and machine learning. And I think this is a real opportunity in healthcare in general to bring together really two relatively siloed groups of experts, both on the data science front and on the clinician side. So we took a look at data between 2000 and 2019 using the UNOS database. This included over 33,000 heart transplant recipients. And what we did was really an apple-to-apple sort of fair comparison of taking the same cohort of data and then running various algorithms to see how we can improve one-year survival prediction after heart transplantation. As you can see, we excluded pediatric patients, those who had prior heart transplant, those who were undergoing multi-organ transplant or had incomplete follow-up. And what we did, the primary outcome, as we would expect, occurred in 11% of patients. So that was the one-year mortality rate. And we split the patients into training and validation sets, just in the usual risk model development kind of approach, in an 80% to 20% ratio. What we then did was do some data resampling that would allow us to basically run iterative models. And we ran 100 different models using each type of 4 algorithms that we utilized for this study. One important point I would make is one thing that we did that I think is actually very important in the machine learning world is we actually combined clinical expertise to help with the variable selection and feature importance. So if you were to take this database and you just hand it to a data scientist and say, go ahead and see what we can predict, they may say that, well, if the patient's zip code starts with 1, it's predictive of 1-year survival, which we know, okay, it may be predictive, but that may be a complete outlier, make no clinical sense at all. So I think it's very important to have clinical output and a collaborative approach to these kind of studies. So we actually had clinicians look through and either group data elements that made sense to be grouped together, either according to clinical values or parameters, or, with various iterations of the UNOS database, sometimes for some years, the data will be collected in one format and transition to another, and there's certain changes, the same thing that happens with the STS database. So we made it sort of make clinical sense before we inputted those variables into the algorithms. We then looked at 4 algorithms, so logistic regression, AdaBoost, random forest, and deep neural networks. And so we ran 100 algorithms for each of those just in the training set. So again, the validation set, again, another important point is the validation set is completely external. And it doesn't see any of these algorithms until you're ready to test the algorithms on that set of patients. And then what we did is we actually did an ensemble approach, which is actually very advantageous when you're doing risk modeling because it'll take the advantages of each of these modeling approaches and put them together to improve overall risk prediction performance. And so that algorithm, the ensemble one, then included essentially 400 models, right? Because 100 each for each of those 4 algorithms, and then you're combining them into an ensemble approach. And we compared this. So we compared the performance between the ensemble approach, between the singular approaches, and so forth. And what we found is we looked at both discriminatory capability. So to test discriminatory capability, which is, in other words, a way to say, how well can the model identify what an individual patient's outcome will be? So you have a patient, they're presented, and you have to predict whether that patient will live or die. How accurately can it do that? Whereas calibration, which we also looked at, is really telling you for a population, what is the percentage of an outcome and how well calibrated is that model according to those metrics. So for discriminatory capability, we looked at the area under receiver operating characteristic curve, otherwise known as the C-index. So a C-index of 1 would be perfect discrimination. A C-index of 0.5 would basically be a coin flip. I would tell you that part of the motivation to do this, I'm guilty of it. I've done a bunch of risk modeling using the UNOS database, and our ability to predict 1-year survival after heart transplants actually modest at best. The C indices for modeling approaches have ranged, in validation sets, have ranged anywhere from like 0.55 to 0.65. That's around where the performance has been. And that's similar to what we found, is that most of the models here that we used, the singular models, were getting AUCs somewhere in the 0.6s. But when we were able to combine these into the ensemble approach, and again, this is looking in the validation set, so the external set, we were able to get an AUC of 0.76. So a more sophisticated sort of approach and performance when it came to predicting 1-year survival. The model was very well calibrated by multiple metrics. There were other things we looked at as well for discriminatory capability, things such as the net reclassification index, which shows like what is the improvement in being able to classify both positive and negative cases. And that was a 72% improvement with the ensemble method versus logistic regression. We also looked at decision curve analysis, which shows you the incremental benefit in prediction across the entire threshold of probability. So if you have risk models that are predicting a various risk across that threshold of risk spectrum, what is the net benefit of using this ensemble method? And you can see that's in figure 4 there, where that green line, you see that there is that incremental benefit across the spectrum. So really our conclusion with this is, again, we're not reaching 0.95 AUCs because at some point you are limited by the data that you have. But I do think the way to fairly compare these kind of algorithms is to use the same data set. So if you were to take an algorithm, but you use, an individual EHR's data and pull 1 billion data points, it's going to outperform anything else that has much more limited data. But using similar data forms and data set, we were able to show that this algorithm can improve risk prediction.
Very nice. I'm very been intrigued by this concept. So we are moving into a new form of medicine where you have the ability to cross-analyze a huge amount of data in a way that we have never been able before. And anything that in this case is mortality, probability of mortality in our transplantation, but next will be model risk assessment in any type of procedure of cardiac surgery, can be done in a complete new way by new analysis that we have never been exposed or we have never been thought as before. So tell us a little bit more of where do you see the future of machine learning in medicine in general, in cardiovascular surgery, and how did you personally get involved? You are a heart surgeon. How did you have this passion? How did you nourish it? What is for a young trainee out there? What do you think about how to get this type of know-how?
Yeah, well, I mean, I think it's, and again, I may be biased, but I do think it's going to be a very large component of how we do healthcare, not just in cardiovascular medicine, but, things like radiology, where you can have an AI algorithm reading, X-rays in 1/1000th of the time with similar accuracy as radiologists. I mean, some of that stuff is already being done and utilized and commercialized, by health systems. I think specifically in cardiovascular medicine, I mean, one area where I see a parallel with this is in the STS, and the STS is in front of this. We've formed a task force on AI and machine learning and working with national databases. We've done similar work, like for example, in AVRs, cabbages, looking at, can we develop better and more predictive things, and should the STS risk models actually be based on machine learning if you're able to improve the risk prediction for procedures? There are some other competing concerns. For example, you want to make sure that the models are interpretable. Does it show you sort of a glass window into what the risk factors are that are coming up with the risk prediction? Because as clinicians, we like to know, what are the risk factors? Are they modifiable? Is it going to change our approach to patient selection or management and so forth? And one thing I will say is not all machine learning algorithms are black boxes. Many of them do tell you exactly, and sometimes even more interpretable than things like logistic regression, where you get odds ratios. Some of these models will actually just rank and tell you, like, what percentage contribution to the model does this variable have? So many of them are very, very interpretable. Beyond predictive analytics, I think that things like imaging interpretation will be big. There's a lot of efforts being put into things like echocardiograms or non-invasive things like coronary CTAs, and developing very predictive modeling approaches that can not only accurately interpret those images, but do it very quickly. So when we talk about healthcare costs and healthcare efficiency, I think there's a huge role for that. The last item where I think there'll be applicability of AI and machine learning in cardiovascular medicine would be data extraction. So if you think about right now, when we think about things like the STS database or the UNOS database, you have coordinators that are trained and paid and they extract the data manually. But things like quality control, variability in data entry, missing data, can be addressed. This is an area of active research because it's easier to take out things like structured elements, like what's the patient's creatinine. That's very easy to extract from, data science and existing algorithms and so forth. What's harder to extract is unstructured data. So how do you take a look at like a progress note or an H&P and extract things, including things like severity of disease? Or how do you integrate that across the health system to say, okay, mild, moderate, chronic lung disease, we have to pull out PFTs, we have to pull out, a clinician's assessment and so forth. And how do you pull that together to make that assessment? And then in an automated fashion, put that into a database. But as you can imagine, I think the STS is already thinking about this. I think this will come down the pike of how do you sort of spread this across the participating sites and then have sort of a standardized algorithm-driven approach to data extraction from the health record. In terms of your second comment, I think this is an exciting time for it. I am seeing a rush of medical students and residents who want to be involved in this kind of stuff. by no means are we experts in AI and machine learning. There are people, AI has existed since the 1950s. There are people who have been doing it for decades, and their entire career is based on AI, not just in healthcare, but across a variety of industries. So I think partnership and collaboration is very important. But there are programs where you can learn more about machine learning. And so for me personally, this was born out of a longstanding interest in risk modeling, using multi-center registries, understanding how we can predict things better. So it was a very natural progression. But there are things like online certificate programs. There are master's degrees you can take. You can partner with people in data science at various institutions that they are begging to collaborate with clinicians and with healthcare providers because they don't know anything about healthcare and they don't know where the role of machine learning and AI may be. But when we form those partnerships, I think it's a huge potential. And I see that's a very, probable route of where this kind of work will go.
Armand, can I ask you a couple questions? I've been really thrilled to watch you take this on. I think this is a hugely important area for cardiovascular medicine. I think that, getting back to, in the small way, prioritizing heart transplant, this is what we need to do to eliminate all the instinct that is part of prioritizing heart transplantation, meaning allocation of organs should be driven by a data approach. That when an organ is allocated, now that we can utilize all sorts of technology to eliminate time as an important variable of where an organ goes, this is how we're going to determine how organs are allocated, based on complex algorithms that prioritize what we want to prioritize, meaning best minimize waitlist mortality, but also ensure post-transplant survival. I think that's one important takeaway for all the listeners, that this is the future. And that when you get an organ allocation, it isn't, well, let's make sure the size is okay. And, do we have enough nurses? And boy, I'm really tired. And what's the PVR? No, you get a phone call that says, we found a heart that has a predictive 1 year post-transplant outcome of X for your patient. Yes or no? And then you do it. And then maybe there's a world where it says, Skynet tells you you're operating at 8 a.m. Just go. You have no choice. My second, thought too, though, is what's next, Armand, is looking at not just predicting death, but really predicting any sort of illness. In other words, how do you couple all the physiologic monitoring we have, add on to it what I do think is the future is using wearables and individual physiologic monitoring, take all that data and say, the system believes that your patient has a risk of readmission of X, or your patient is about to go into atrial fibrillation. You may want to start doing something about it. I think that's the future that you're beginning to carve out and pioneering in. Third comment is, can AI stop bleeding? Because that's really what I really need. But Armand, I'm immensely proud of the stuff you're doing here. It's in your own quiet way. I think you are leading something that is immensely important and really is going to shape the future of how we take care of patients. So really nice work.
I completely kudo Dr. Shah. Congratulations. Really was very interesting to me to read your paper. I'm in a completely different niche in the world of cardiothoracic surgery. My passion is robotic coronaries. And, after I read your paper, I thought, can we take the entire patient population that needs coronary bypass grafting, do a CTA, and exactly define a mammary artery and teach a robo how to take down a mammary artery automatically based on the individual CT scan for that patient. If I can teach a Tesla to drive in Los Angeles, I think I can teach a robo how to take down my mammary artery after I did a CT scan on myself, and the robo knows exactly where every collateral is, no? So it's
yeah. Look, that Google agrees with you.
Yeah,
and Google actually thinks that all of our experience is like the Matrix. That you can digitize Armand's expertise and your robotic coronary expertise digitize it, and then, plug it in. If if the machine can learn, how to defeat a grandmaster in chess, knowing the rules, and then defeat a Go master without knowing the rules on an order of months, maybe all the stuff that we're doing is completely digitizable and not all that complex. Although,
Yeah.
I hope not, because guess what? Machine learning can't stop bleeding.
Yeah, that's absolutely a great comment, and we all looking forward to maintain our jobs overall. I mean, we love what we do. So, Kiki, I give you your words. Tell us a little bit. What do you think? When I know you're also a personal friend of Arman, so just I'm sure you will be nice with him. But just
Arman, it's very impressive work, and certainly I think I would agree with Ashla. I think what you've done is really set the bar quite high for what can be done and what should be done in this field. I think the natural question that I have as I look at these types of machine learning algorithms in healthcare and well beyond its role in cardiac surgery specifically. But I guess my natural question is, yes, I think there's a role for improving efficiencies. I think there's a role for reducing costs. I think there are opportunities perhaps to even reduce some of the staffing constraints that we have more recently seen. But I do wonder if you foresee a scenario in which some of these algorithms will be used as a means of curtailing or reducing access to care. That is to say, if some of these predictive models suggest that a certain individual might not expect a particularly good outcome, what role do you think machine learning is going to play in that discussion, in that conversation? And perhaps more broadly, how do you think you're going to be able to convince the population at large, the patients, the consumers of healthcare, to understand how important this is and how it can be utilized to make what are perhaps system-wide decisions that are good, but perhaps don't appear to be all that good for the individual?
Yeah, I mean, I think those are great comments. I think for the first one, Keki, I think that that's why it's important that the models are interpretable, because, if for some reason it were to bias, so let's say it identifies a risk factor, whether it's gender of the patient, race of the patient, let's say HIV status, for example, it says, yes, if it has these risk factors, we're going to sway whether it's allocation in heart transplant or risk prediction, but you have no idea that the model is using those risk factors. It can absolutely bias against patient populations. But you have to remember, for example, in the STS, those risk models have some of those risk factors in it. That doesn't necessarily mean we're looking to sway care away. We're just trying to look to accurately assess risk prediction. And so, but to that point, I think that again stresses the importance that if we are going to use some of these algorithms, there has to be visibility of what risk factors it's identifying for that very reason. And I think it also lends into your second point, which is to have clinicians trust these algorithms, they have to know what it's doing and how it's predicting and what risk factors it's including and what weight it's giving to each risk factor. So like I said, I mean, there are many of them that do provide that, and they provide it even sometimes in a more interpretable way than traditional approaches that we've used. I think that's the main takeaway, is that we need to use, algorithms that have some of that visibility. And can you remind me, Keki, what was the second question again related to?
The second question was really, how do you get buy-in amongst the patients? This is going to be part of the decision-making process. I guess even beyond patients, even insurance companies for that matter, I imagine they would have an interest in this. How do you get all of those basically end users of healthcare to recognize that this is the future and that this is something that really is critically important?
Yeah, I mean, there's been a lot of conversation about things like, will AI tarnish the, patient-physician relationship, which is already, those conversations are already being had. How do you get them to trust and what is the error rate that we would accept for an AI system? So that's a really interesting question, because to me, an analogous example is the self-driving car. You have a self-driving car that goes and plows over somebody riding their bike. That's a huge problem. but humans driving cars go and plow people over all the time. So even if you had a world where it was all self-driving cars, and let's say that error rate or accident rate was much, much less than with humans driving it, the question is, what is that litmus? Like, what is acceptable from a PR perspective for people not to run away from the technology? So that's something that has to be developed and discussed. And, one thing I would say is I very, very strongly feel that clinicians have to be the gatekeepers for all this stuff. 100%, because it'll help address all of those things. There's never going to be a time where AI replaces everything and then we're all just sort of useless in there in case a problem happens. We're going to be the ones using it as adjunct technology to improve what we're doing, or to do things that don't really need our level of expertise so that we can go do other things that do require expertise and do require more of our time. So I think, a lot of that is in, discussion, and I think it depends a lot on the technology. But I would say that, again, a lot of that I think can be quelled by clinicians really being the gatekeepers to this kind of technology and figuring out how can we use it, and then communicating to the community at large that here's the benefit of using this and here's how we're going to control it. But ultimately, the decisions will be up to us as clinicians.
Fantastic. My comment is, Arman, please create some new algorithm that will allow me to reduce the number of epic click that I have to do every day. So that I'm sure there will be a lot of people very happy if you become multimillionaire if you invent something like this. Please. Earbuds, your word.
All right. I think we're nearing the end of our time here for today's live talk. Thank you very much, Dr. Killick. I think some of my main takeaways from your paper, it was a beautiful statistical exercise and very well presented. I think, like you mentioned, we have to improve transparency of these models, talk more with the relevant people to educate everyone about the benefits of using such risk models. And also, I think there's room for development in terms of optical character recognition to make more out of data and progress notes and entries that are not recorded as specific data points, but require manual extraction. I think all these are areas of exploration, and clearly the model showed much stronger prediction than the traditional models that we're used to. I think this was very productive and educational for all of us. Thank you again, Dr. Killick, Dr. Balsara, Dr. Shah, for joining us today. I think with this, we'll sum this up. Gianluca, do you have any final words? Yes, I will
close the broadcast, and thank you again for participating. Thank you for this nice conversation. I know you guys are also on call, so I let you go for your hard work. And thanks again, everybody. Thank you, Dr. Shah, and good night. Bye-bye.
Thanks, everyone.
Thank you, guys.
Fun.
Bye-bye.
Thank you. Thank you, everyone.